Hi everyone, welcome to MSB. Today we are going to talk about the basic histomorphological features of psoriasis and its differentials. Psoriasis is a chronic relapsing skin condition with complex pathogenesis including immunogenetics and environmental factors. It has several clinical histologic variants. Common histomorphological features are regular acanthosis with elongated terete ridges, thinning of suprapapillary plate, hypogranulosis, parakeratosis in the stratum corneum with mounds of neutrophils known as Munro's microabscess, neutrophils in the spinous layer forming spongiform pustules of Pogos, dilated and tortuous vessels in the papillary dermis, perivascular lymphocytic infiltrate in upper and middle dermis, and subcorneal pustules in pustular psoriasis. There are a number of conditions that can have almost similar histomorphology. Common differentials include seborrheic dermatitis, subacute spongiotic dermatitis, pityriasis rosea, inflammatory linear verrucous epidermal nevus or ILVANE, lichen simplex chronicus or LSC, and pityriasis rubropilaris. Pustular psoriasis can mimic acute generalized exanthematous pustulosis or AGEP, subcorneal pustular dermatosis or SPD, bullous impetigo, pemphigus foliaceus, and IgA pemphigus with SPD variant. Now let's see the basic distinguishing features of these entities. Seborrheic dermatitis has spongiosis and mounds of parakeratosis and follicular ostia. Spongiotic dermatitis has marked spongiosis and eosinophils in the infiltrate. Inflammatory linear verrucous epidermal nevus or ILVANE often presents as unilateral intensely pruritic plaque along with line of Basco involving lower extremities during early childhood. Histomorphology demonstrates orthokeratosis and parakeratosis in the corneum overlying hyper and hypogranulosis respectively. No neutrophils in the corneum or epidermis. Lichen simplex chronicus is a chronic dermatitis characterized by an itch-scratch cycle resulting in a thick scaly plaques of the skin. Histomorphology shows compact orthokeratosis with focal parakeratosis, hypergranulosis, irregular acanthosis with curvilinear blunt rooted ridges, vertically oriented collagen bundles in the papillary dermis, no neutrophils in the corneum. Pityriasis rosea is an acute self-limiting papillosquamous disorder in young patients that starts with a slightly raised oval-shaped hiral patch followed by similar lesions within 1 to 2 weeks in a typical Christmas tree pattern. Almost identical histomorphology except presence of erythrocyte extravasate and less vascular ectasia in papillary dermis and absence of neutrophils in the parakeratosis. Pityriasis rubropilaris is a chronic idiopathic skin disorder with characteristic histologic finding that include checkerboard pattern of alternating ortho and parakeratosis both in vertical and horizontal directions, follicular plaguing, psoriasiform epidermal acanthosis with broad rete ridges, thick suprapapillary plates, and normal to increased granular layer, no intercorneal neutrophils. Now let's have a look on the differentials of pustular psoriasis. AGP is a pustular drug reactions commonly associated with beta-lactam antibiotics like penicillins and cephalosporins. It generally resolves in 1 to 2 weeks after withdrawal of offending agents. Histomorphology is non-specific and mostly similar to pustular psoriasis except presence of dermal eosinophils. Definitive diagnosis requires clinical correlation. Subcorneal pustular dermatosis or SPD is a rare pustular eruptions of unknown etiology occurring in middle-aged women. It has almost identical histomorphology. Bullous impetigo is commonly due to staph or streptococcal infections that affect hands and face of the children. Pus culture and the presence of bacteria in the bullae help in diagnosis. Pemphigus foliaceus displays subcorneal acantholysis, intraepidermal eosinophils. Direct immunofluorescence shows intracellular IgG in superficial epidermis. In IgA pemphigus SPD variant, blister cavity contains both neutrophils and eosinophils. DIF demonstrates intracellular IgA.